Thank you, Chris, for covering this topic for our youngest cohort of survivors. I wanted to reflect just on a couple of themes that came up both in Barb Anderson and Chris in your talk about the fact that how we do physically affects how we do emotionally and socially, and it really is an integrated system, and sometimes we forget that we're treating one part of it and ignoring the other part of it. So I think that's a very important message. I can also say from sort of bird's eye view, looking at the research portfolio, which has been fascinating to me, is we have in some ways disproportionately larger portfolio of studies among childhood survivors, given that they are a very small part, because these are typically rare disorders, in the constellation of grants that we fund, because they've also been the vanguard of our survivor movement. And what's interesting is the early studies in children were conducted by MDs and focused very much on the medical sequelae. What we're seeing now, childhood cancer survivor studies helping us do that, is shift gears and now looking at the long-term psychosocial and functional and social engagement outcomes in that population. By contrast, in the adult arena, the majority of the studies were conducted by PhD investigators looking at psychosocial outcomes and not looking at the medical sequelae, so thinking of fatigue, depression, pain syndrome, sexual dysfunction, and we're now shifting in the adult into the more medical. So it's a nice rebalancing that's occurring in the portfolio. The other comment I think is important to remember, many patients do remarkably well. And we keep reminding ourselves, but we know there are subsets of individuals who are at risk, and our task, of course, is who are those individuals, and can we intervene early and prevent what might be catastrophic outcomes, suicide, to me, being the worst possible endpoint there. And before I ask our last speaker in this session, before we move to panel to come up, I just want to reflect this, again, Barbara Given is going to come and talk to us about caregiving. I'm always, whenever I go on this topic, I'm always reminded of a wonderful quote that Rosalind Carter is, to which she's attributed, this quote is attributed to her. She, of course, wife of former President Jimmy Carter, very big advocate of family health and well-being, her Carter Institute, very focused on that. And she said there are basically 4 kinds of individuals in the world. You either are a caregiver, you were a caregiver, you will be a caregiver, or you're gonna need a caregiver. So we don't, any of us, ever get out of this without caregiving, so Barbara Given is gonna talk about that.
Thank you very much, Julia, and thanks, Hetty, for setting the stage and for such a wonderful presentation. And I'm thrilled that we have caregiving on the topic. And as Julia said, this has been something that I've been advocating for many years. We were funded in 1988 for our first caregiver study, so been at this for a while. So my charge today is sort of an overview and of what we know about in survivorship as far as caregiving, and sort of setting the stage, hopefully to make some recommendations for research and also some policy. And so as you've heard all day today, we know about the increased demands that are happening to the patients, and certainly in the caregivers, as we are now doing more and more things in the home and less in our formal settings. And so there's more responsibilities that come to the patient family members in their home to do that. And if we think that the patients get lost in the system as it deals with survivorship, I would just ask you to look at your survivorship care plans and see if there is a mention of family at all, or even in the guidelines, because in our community settings where I function, family is not even mentioned in the care plans. And families get lost in the system, and the importance that they contribute to our healthcare outcomes is also missing and absent. Most of the work that we know about survivorship has to do with our prostate studies or our breast cancer studies. The work that's really been done longitudinally has primarily come out of most of the studies, the American Cancer Society studies, which was the longitudinal one, and Young-Mi Kim probably has been author in most of the publications. And in going back and trying to review the literature, We have about a decade where it is only that writing and the CanCore writing that deals with survivorship and even mentions the caregivers as a partner or as a piece of the data that's done. Now, in the last couple years, you'll notice some of my slides toward the end, there have been a few studies of longitudinal follow-up that have come out in 16 and 17, but they're primarily absent. We know a lot about caregiver burden, distress, depression, in all other phases of caregiving. We know a lot about it in dementia. Dementia really has taken the field of where our knowledge is in caregiving, but we see virtually nothing mentioned about that in the survivorship period. And yet, the few studies that we have indicate that caregivers are still assisting patients with distress at 5 years, and it gets less and less toward 8 if the patient is still surviving. We also know from the few studies that have been done that there is interdependence between the psychosocial dimensions for the patient and the caregiver. In other words, their depression, their anxiety affects each other. But we do know from those studies also that there is unique needs and unique psychosocial dimensions that happen to the caregiver. We have fewer studies even that look at the social relationships or the work relationships. So if we, in the studies that we have, we look at anxiety and depression and coping, but we have very little on the social dimensions or the work dimensions in the survivorship phase. And there are a few studies that really look at interventions in this phase that might affect the caregiver or the patient's outcomes, or that we really have made it easier for the family caregivers to get through this period of time. And there are virtually no dyadic studies, true dyadic studies. I mean, we may study them separately, but dyadic studies. And in all of the studies that I could find, we see that documented training or teaching only about 25% at all of the phases. And in the few clinics that I saw on comprehensive cancer centers that might have something for caregivers, it's usually around psychomotor skills and not really about how to deal with depression or anger or some of those other things. There's little consideration of the effect of family caregiving on the caregiver's own comorbidities. And again, in dementia many, many years ago, at Seattle, they did some work on looking at the effect on diabetes, hypertension, and renal disease, but that has not been replicated that I was able to find, and certainly not in cancer patients. And at 2 years post-diagnosis in the work that we have, still a third of the caregivers are dealing with their own coping. So it remains an issue. So what do we know about the care that caregivers give? Not very much. We know not very much about the knowledge and skills that they need to provide the care that they do, especially as we're getting into the new modes of treatment of immunotherapy and the targeted agents. We don't know how to help families with their own coordination of care that they are going to have to do. We know little about the change in role and role relationships across the various phases from 1 year to 3 years to 5 years to 8 years. We do not know anything about the quality of care. If I were pushing for one big study, it would be what do family caregivers do that help the patients have better outcomes or promote the patient's long-term better outcomes in their care. In other words, patient reported and patient not reported outcomes. We know very little about that. Therefore, we don't know if they give too much care, too little care. We know little about could they have identified an early complication earlier than they did. If they did, would that have cut down on the length of stay or the morbidity of the complication that occurred? We have most of our interventions that we do have, whether it be for cancer or for dementia, are really the cognitive behavioral interventions. What if we tried some of the other strategies and some of the other approaches? What would happen? And what about the coordination and transition care? if we look at what the caregiver experiences, we see in the studies that still at years 2, again, this primarily comes out of the American Cancer Society studies, that anxiety, depression is there. We see out of one of the general national studies that the cancer population had higher periods of anxiety and depression than some of the other caregiving populations. We're looking at PTSD now on a very, very few studies, not very much. Again, if the studies that are out there are primarily in dementia, not in cancer. We see that there's very few studies on social support. In the caregivers report, there is lack of social support, especially as they get to 2, 3, and 5 years, because everybody wants it to be over. We're ready to move on, and so we expect the caregiver to be ready to move on. And that lifestyle changes are still occurring as late as 2 years in the documented literature that we have. And one of the major fears is the reoccurrence and the progression of disease. And I only could find one spiritual study that had much on spiritual, and it just showed that the caregivers' needs were heightened in long-term survivorship, not necessarily the patients, but the caregivers. Other caregiver responses at 2 years or longer include the financial challenges, the lifestyle challenges, and other challenges that occur. But a big one is who's in charge, and we've certainly talked about that a lot today. You know, is it the primary care person? Is it the psychiatrist? Is it the occupational therapist? Who is in charge? And that is a major issue for the caregiver of knowing who to go to, who to report their concern to, who to ask the question, who will be able to answer that. And the resources that are available are often not made available because I think our professionals don't know what is all out there. And given that we're going to have a more aging population that caregivers are going to deal with, cancer centers really need to look to the aging services that are in the community and recommend to the family caregivers of cancer patients taking advantage of like the respite services, like the transportation services, like the meal services, and a variety of other things that are available. In the work that's been done, the quality of life of the family caregiver at 2 years predicted their quality of life at 6 years, so it's not over. So we need to continue being responsive to the needs of the family caregiver. The information needs, there are a couple studies out that are talking about the information needs of the family caregivers. And these are the categories that come out in the studies as the frequent things of being needed. And we had a caregiver recently talking to us who indicated that they couldn't even get the stage of disease from the provider. The provider didn't want to deal with them about that. If the caregiver wanted to know, the patient could tell them. Well, the patient really was not one who was sharing things, so she was quite upset that she couldn't even know that because that affected all the certainty and the expectations and the planning for her life. We also see that people don't get that information, so they quit their jobs or change their jobs or make the employment changes, and those are premature decisions that really have the long-term effect. And so we see that being reported as well. And caregivers report really needing help, as I alluded to earlier, with how to deal with long-term depression, deep depression, anxiety, anger, and things. And those are not things that we teach, or we refer to them to modules or educational sessions. So some of the tasks of care that evolve from all of this, and again, you heard this pretty much all day today, is what are the problems the patient has. If you think of the problems the patients have in survivorship periods across the period, you can think then back to what the caregivers are involved with. The problem solving and decision making, sometimes on their own, sometimes together, sometimes in conflict with family members. The symptom management, again, we saw today about the long-term symptom management, the residual effect, the continuing effect, and then, oh, by the way, 3 years, 5 years later, we have the cardiac effects that they may or may not have been prepared for. And again, we hear stories of going to ERs and being treated and being worked up where nobody asked anything about medical history, and the cancer diagnosis was not given. And so we started a trajectory of treatment that was inappropriate given the fact that the patient had the cardiac problem, had a cardiac toxicity. And now with all the new drugs and treatments, we have family members getting involved in actually getting the medication, receiving the medication from the specialty pharmacy, and then doing 2 weeks on, 2 weeks off, then titrating the doses different, then having a rest period, then the next trajectory is different than the first trajectory, and they're on 7 other meds. In our current study, the average number of meds our patients were on beside their oral agents was 8. So we are now integrating all of those into the targeted agents that the family members are taking. And then the family members indicate that they're performing complex tasks for which they did not really have the diagnosis or have the prior preparation for them. And yet they are also responsible for remembering what the follow-up care is. And we saw a slide earlier today that talked about the follow-up care not being specific. Sometimes we have the plan of care, the survivorship plan of care that talks about it. But again, if you go back to the guidelines, and like NCCN guidelines, and you look exactly what the follow-up of care is, it would be a mystery to the family caregivers as to what they were supposed to do. So as a provider, as professionals then, these are some of the areas that we really need to work with to assessing the caregiver situation. As we heard before, not every caregiver needs our help. Not every caregiver has a bad situation. Some of them do very well. Some of them have situations that don't really need that. But a lot of them need help. And so as professionals, we need to look at the caregiver's mental and physical health. We need to look at the caregiver's multiple other roles. And again, very often, it is the younger caregiver who has the problems because they have multiple other roles and competing roles. Then we have to try to find out if there are decisional and family conflicts around the decisions that are actually made. And if there's a big transition complexity about where they're going to go, are they going to go to rehab? What if they go to rehab and then fall and break a hip? Then how do we start the trajectory all over again? And these situations happen on a regular basis. And what is the complex needs that follow? Those are things that we have to do as a part of our professional assessment. And then the risk factors for negative situations are if the caregiver has a lack of choice. So when you get into adult children and daughters-in-law, there are the lack of choices that sometimes occur. Are you expecting serious late effects? And do you know what the late effects might be? And again, with some of the newer agents, we don't know what those late effects are going to be. And then the older adult has multiple complex comorbidities, and how do those interact and how do those have a problem? So again, in our study, we had as many hospitalizations for the comorbidities as we did for the cancer during the period of time that they were on the oral agents. And then all the poor communication issues. So whenever we have these are other reasons for the professional to know that we're going to have a more complex situation to get through in the various ways. And so I think the professionals need to be aware of, and this is the other thing that I think we would have caregivers telling us a lot, professionals don't know the resources, and if they do, they don't recommend them. It is not something that is a part of the care, because remember, the caregiver is not a part of the team, and so it is not part of who discusses what with them. So we need to look at community support groups, and we need to look at the cancer support community. In a lot of communities we have those, some we do not. I think we need to do boot camps for caregivers. Again, some communities do those. In some states, the cooperative extension services will do boot camps for caregivers, more for dementia than anything else, but they are doing them. So again, I think we need to approach them to think about cancer. I think we've talked all day about the training of professionals. I think we need to look at community colleges doing programs on weekends. I think some community colleges have done those in the past for dementia. Again, dementia has done more than others. But there are some of the general caregiving for dementia that would work for anybody because they're general supportive kinds of things. And then we need to look at peer network, social media, and social media support groups, because I think those are out there. And then we have to think more about technology and how we can use technology and how we can have hotlines or resources for family caregivers if we need them. Again, using dementia as an example. Other resources to think about is the internet. 78% of caregivers in the various surveys that have been done indicated that they have looked up the condition online, and that's where they've gotten a lot of their knowledge. So we need to think about what ones to use and recommend the best ones. We need to think about using, like AARP has a number of video clips on injections and again, psychomotor kinds of skills. We can refer our caregivers to those. I think we need to develop toolkits of resources and make them available or refer our caregivers to them. I think the health system needs to get involved in thinking about, we heard some of this today for patients, but I think we also need to look for guidelines and standards and benchmarks for our family caregivers. We also need to think about measuring the quality of care that caregivers provide. I really think that we really need to do that. Probably not just for cancer, but for others. And then really think about what curriculum we need at the basic education for our professionals, but also then for continuing education. And I know ASCO is getting some things ready on this. And then health professionals need to have this as sort of their assessment guide as they deal with family members, and thinking about what are the demands that's going to be on the caregiver for the hours of care and level of care. How long is this going to happen? Again, most caregivers don't have any idea whether this is 6 months or 6 years. They haven't really been guided to know how intense this is going to be for a period of time. And then also think about other demands that they have and what knowledge and skills they have. And remember that we need to consider the caregiver as a part of our plan of care, that everybody hears about it. For research, I think we need to have a variety of studies to really look at the surveillance and intervals of survivorship, look at 1 year, 3 years, 5 years, probably do another ACS study, but focusing much more on some of the things that we know. We need to do much more with vulnerable populations, rural, racial, ethnic, and the various things that happen. If you are a Muslim in care, or in Michigan, we have a lot of different minorities. The measures that we should examine, the measures we should examine for the patients, the measures that we should examine for the caregiver as a result of the caregiver being involved. And we should think about family navigation in survivorship centers or for survivorship. And research through targeted interventions affect employment. If we really do this, can people continue their roles that they have without drastic changes? We know that about 25% of them make employment changes, either retire early, go change the way that they work, or actually change places of employment. We do not know much about the utilization of caregivers during their period of time that they are involved with caregiver or immediately after. And what we need to, again, develop toolkits to go through that. For policy, we need to look at the effect of the role on the use of service and well-being. We need to have a care type. So the AARP has care acts that have passed in 39 states where a caregiver must be identified at hospital stay, and that caregiver must be taught at the end of that. Well, I think we need to think about that for survivorship. That's all around skilled care and more around for the person who's really going to need a lot. We need to think about that for longer periods of time. Or engage groups like AARP, who got this in 39 states in 2.5 years. So we have to think about things like that. We need to think about tax credits. Again, dementia is doing that. We need to think about workplace accommodations. Those seem to have gotten lost. Again, a few years ago, those were more evident than they are now. There's an HB 2505 Credit for Caring Act that has been introduced but is sitting there in Congress. The big question is, who cares enough to pay for what caregivers do? And until we get enough data, until I believe it shows what we do on patient outcomes and will improve the quality of care we give as professionals, we'll probably not get there. So we have a big, big role ahead of us. But the bottom line for me is family caregivers are that hidden care group. We need to recognize them, we need to value them, and we have to include them in the care that we give in an overt way, not just in a covert way. Thank you very much.